Hey everyone, happy Monday. In today's edition of Clinical Recap, I have an interesting case that came in. So, in today's case, I have basically a 16-year-old male complaining of both the lower legs, especially after playing basketball. No history of fall or trauma. The pain is roughly for about 2.5, 3 weeks, and he complains that as soon as he starts to play basketball, he starts to get the pain in the leg within its first game, and as he keeps playing, the pain only gets worse, and it starts to get better as he rests. Initially, it would resolve quicker, but now in the last couple of days, the pain lingers on for the next couple of hours. It's roughly around like that region here, like on the leg on both sides. One side is not worse than the other. That since the start of spring and summer, he has increased his activities overall, and he started to play a bit more, while in the winter time he was only working out in the gym. Now, any kind of workout in the gym does not seem to provoke the symptoms. For example, lunges, split squats, Bulgarian split squats, elevated split squats, calf raises, none of these exercise seems, biking doesn't seem to be triggering the pain, but it's really basketball, any kind of running, any kind of movement which seems to be bothering his leg a bit more. So just based on that information, I'm just curious, what are you guys thinking? Like, just let me know some answers and I'll give you my own thought process, and I'll try to get a little more assessment and some details of what I have been doing. So just let me know what you think about this. So I'm not too sure about this since the pain is nowhere close to the knee. There's no history of trauma or fall. There's no sudden onset of pain. So the pain seems kind of far away from that side. Yeah, possibly, but maybe fibula as well. So I'm not too sure about this either, just because number one, there's no knee pain, and number two, I'm not sure how we can probably suspect a muscular imbalance just based on the subjective history that I've given so far. Maybe with objective. Yeah, possibly. That's what I'm thinking too. So possibly shin splints, yes. Achilles tendonitis, I'm not sure about that just because it's just not around that area. He's not complaining of any heel or Achilles pain. Pain history, it's a dull, deep. So not sure about this either just because the patient is 16 years old, fairly young, has no history of back pain. The pain itself is like constantly at the same site, so it doesn't sound like much like nerve pain, and plus it becomes worse with activity and better. Definitely that, but also I wouldn't rule out the fibula because that also has a mild chance of developing any kind of stress syndrome at that site too. Plus the pain is also on the outside. Excellent replies on the question I asked yesterday, and I got a lot of replies. A lot of them are repeated, so I won't be sharing all of them, but I highlighted the ones that seem to resonate with my clinical reasoning the most in the next story. Hey guys, so as you can see from the responses, those are the things that I'm thinking of when I see somebody with those kind of symptoms and the subjective history that we discussed. Now, in Canada, we are physiotherapists are self-regulated, so we don't need prescriptions from the doctor to see a patient. But having said that, that leaves the burden of assessment on us to make sure that we are screening patients for some red flags, and if is not the right candidate for physiotherapy, then we should be referring them out to rule out any potential red flags. So when such a case happens, before I go into any other muscular problem, we are trying to rule out any kind of vascular compromise, compartment syndrome, or exercise-induced compartment syndrome, and the second thing after that's ruled out would be any kind of a bone stress injury. Hey guys, sorry, so I didn't get a chance to finish my story yesterday, just got super busy with work, but the first thing I want to say is I put in red flags for vascular compromise or bone stress injuries. Just know that bone stress injury is not a red. You can definitely treat patients with that. It's bone stress fractures that we are more concerned about. So just to kind of clear the air about that. So to follow up on that, as we've established those two conditions we want to rule out, so some of the things that I'll check with, say, compartment syndrome is any excessive swelling, change in color of the leg, any shiny, scaly skin, looking for the dorsalis pedis or the posterior tibial pulse just to make sure I'm getting that, no excessive diffuse pain or redness. Those are some of the signs I'm looking for. Now in his case, he did not play, and he came saw me in the morning, so he hadn't played for a couple of hours, so I did not see any of those symptoms in that condition. And he did mention that he did not find that when he played basketball any of those things were affected. So kind of rule out a little bit of that exertion compartment syndrome. And then moving on to the bone stress injury. In the bone stress injury, I did a little bit of bone stress injury. That's what I'm really thinking of. So one of y'all answered the question where you mentioned the age of the person, and if you look at the age that I mentioned, my patient was 16 years old, so he's right skeletal maturity but not quite there yet. So that's a very important consideration to note for definitely more in females, but also for anybody who's around that skeletal maturity age. So based on that, I started to really the tibia, the fibula, and he had some local tenderness right on pressure on the bone there. So that kind of raised my suspicion a little bit more. And then the next one would be to load it up. So first I had him just walk with and so finally just to load it up, I had my patient do some pogo jumps. So just some plyometric drills, like just jumping on one leg and the other, and that instantly brought the pain. So basically I wrote a referral to the doctor, and off he goes for some further investigation. Hey, what's up guys? Just a follow-up question from our stories. So what would be your preferred gold standard examination to diagnose a bone stress injuries? Let me know in the poll here below. Hey, happy Friday everyone. So the results from the poll question that I asked yesterday are out, and the least amount of replies were on the MRI, but unfortunately MRI is the most accurate way to find a bone stress injury. Now you guys are not around or x-ray, you can pick it up in those imagings as well, but it's only that you'll find them in the more severe cases where you've had a full-blown fracture or multiple hairline fractures. But if you want to kind of assess, try and figure this out early in its early stage, then MRI is the only accurate way to find it, because the others may not show those slight bone stress injuries or smaller fractures. So this is the end of this segment. Hope you enjoyed. Happy Tuesday everyone, Abhijit Minhas here. For those of you who are new to my page, welcome to the clinical recap series, and my goal with this clinical recap series is just to shift our focus and perspective from focusing or spending our interventions and treatment modalities and thinking less on those terms and thinking more on terms of like clinical reasoning, critical thinking, things which come really handy in musculoskeletal and orthopedic, and that's what I tried to cover in this. So back when I was a student, I used to hear this all the time. I used to ask about a particular treatment and what I could do for certain patient, and some of my professors and my seniors used to always keep saying focus on the assessment, don't worry too much about the treatment, and I always thought that they probably just do things right, but that's not the case. Now looking back in hindsight, 10 years being in this profession now, what I do realize is the reason we don't want to spend too much time on the intervention part, in the sense that we don't want to think too much about techniques, is because we now know that a lot of interventions work for a lot of different conditions. So whether you like to dry needle a certain area, do acupuncture, do hands-on or manual therapy with an instrument, kinesio tape, maybe use exercises, active exercises as a means of modality, they all work. But really, to understand the problem, we need to be able to critically think why this person is having this pain in the first place, and that's the real challenge. All right, with that little spiel out of the way, today's case on the clinical recap is a classic exercise on clinical reasoning and critical thinking. Some of you may have heard a similar case from me in the past, but this is a totally new case. So I had a mid 70-year-old patient, female, come in with pain on the IT band on the side of her left leg, which has been going on roughly for about a year, on and off, but progressively getting worse. She went to her doctor. Her doctor said that there's an IT band problem and has sent her for physio to me, right? And now, so when I started to ask her a couple of questions, I found out that it wasn't an IT band problem. And the reason for that is, again, critical thinking. Mid-70s, I asked this person if she had increased her volume of exercise or started anything new, and she said, on further questioning, she told me that a lot of her pain was happening, especially if she was standing for too long, or especially at night, and she had a hard time sleeping. And There was no, she liked to walk, but nothing crazy. There were distances that she's been doing for years and had not changed, and was no change in her volume or intensity. More so, she complained of discomfort, pain, a little bit of tingling, and a sharp pain on the side of the leg. So, without even getting into the objective assessment, and just based on the things we hear from subjective history, how often do you see a patient who's in their mid 70s, not really active, fairly sedentary, and has the leg, especially when they are sleeping at night or when they're standing for too long, to have an IT band problem? From my understanding of an IT band problem, that tends to happen with more active individuals or people who have started to do some kind of a new sport and an activity, or increase their training volume or load, which can sensitize the side of the leg. But to have it in a person where they haven't been doing any of those things and getting pain, also complaining of stuff like numbness and tingling, sharp pain down the side of the leg, does not really sound too much of an IT band problem, in my opinion. So this is such a common pattern that I've been seeing over the years in my clinical practice. So when something like that happens, I'm thinking L2, L3, L4 sensitization. So some of the things I look at are her posture. So if I see an excessive lordosis, when itself is not stuck in that kind of lordosis where there's some kind of spinal extension, may be causing some irritation of the L2, L3, L4 nerve root. So I'll do some neurological testing where it seemed like sense of vibration and light touch were decreased on those. So we worked on certain exercises to improve mobility and flexibility through the lumbar spine, and as we did some repeated motions, some McKenzie style exercises, but in flexion and other movements, those symptoms started to rapidly centralize, and then she got a bit better. So like I said, this is a case of a good exercise in clinical reasoning. So if you're basing your clinical impression on the fact that the doctor said it's an IT band problem, or there's from the hip to the knee on the side of the leg, based on those two things, and then you probably have the urge to dry needle it or roll it out or stretch it, I would say maybe this would be a good way where you think clinical critical thinking to see if it's truly an IT band problem, rather than focusing on like the treatment options for that. Great question. So I did not do any of those tests because I've seen these patterns, and really with practice it's all about pattern recognition, and when I can find that I'm able to centralize symptoms just based on lumbar movements, then I stick to that and I don't work. Another great question. So lumbar spine maybe, but SI joint I'm not sure. I don't even think the SI joint is responsible for half of the things that we claim that it causes, so I'm not big into doing major assessments or treatment.